your friends and ask to join. Registrars who has joined. So we'll wait for a few minutes if people are joining. Good evening, everyone. Today we have another Senior Registrar Forum. It's the 5th Senior Registrar Forum of the year. This is actually brainchild of our own President, Dr. Ganaka Senaratna. Today we will be discussing about blood and blood products, transfuse or not to transfuse. And before starting, I would like to invite our President, Dr. Ganaka Senaratna, to have a brief address of the audience. Over to you, Ganaka.
Thank you so much, Premali. Good evening, all of you. Sri Lanka College of Internal Medicine has been functioning under the theme of enhancing clinical excellence, capacity building, and human care in the year 2022. So, SR Forum is one of iconic projects that we've been conducting, which we believe that it should help our senior registrars to become competent, compassionate, and confident internists in one day. To that, since it helps them to build up their capacity and enhance their clinical excellence. So I would welcome all of you for this 5th session, especially Dr. Dileetha Kuruppu, consultant transfusion medicine physician from Peradeniya. Thank you very much, Dileetha, for accepting our invitation and doing this for us. I should also thank Priyamali for passionately and energetically leading this project, which will be definitely a real help for our senior trainees. So without taking much ado, I would like to hand over the podium to Priyamali back again. Over to you, Priyamali. Thank you so much.
Thank you, Ganaka. So today we are going to talk about blood and blood products. You know, we are having not like good old days. Now everything has developed. So we need to know things about transfusion. Sometimes when we want to transfuse, transfusion physician will tell not to do. So if she want, we don't or not. Like there are issues. So I thought this is one of the good topic to discuss, and my good friend Dileetha Kuruppu agreed to talk about this. To introduce him, he is actually a very good friend of mine and my batchmate who is currently working at Teaching Hospital Peradeniya as a transfusion physician. So without taking much time, may I invite Dr. Dileetha Kuruppu to start his discussion. You can ask your questions. We will unmute you once we finish the discussion, and you can have your questions through the chat box and questions. Over to you, Dileetha.
Thank you, Premali, for your kind introduction, and also thank you very much for the president and the council of College of the Internal Medicine for inviting me for this talk. So I'll share my screen. I think you all can see my screen.
Yes.
Right. Thank you. So I'll be thought of discussing you about the blood and blood products. When it comes to blood and blood products, you all know thoroughly about the blood and blood products from your internship. But the theme line to transfuse or not to transfuse, because of new and developing trends and the data that we are getting every day, we sometimes transfuse and sometimes not transfuse to some indications where we transfuse in our few years back. So the outline of my talk is about the blood transfusion chain, little bit about the blood transfusion chain, then the patient blood management and effects of blood transfusion in medical patients, and effects of FFP and platelet transfusion in medical patients. These two are most controversial areas when it comes to the transfusion in medical patients. And I'll introduce you a few alternatives to blood and blood products at the end. So the blood transfusion chain start from donor vein and it's end up in patient's vein. So you involved in the latter part of this blood transfusion chain where you prescribe blood, request blood and start transfusion, and you manage a transfused patient. So the most important thing in as far as you are concerned is the prescription. Like any other drug, you have to prescribe blood as well. The prescription should comprise the component that you are intended or you are thinking of transfusion to this patient, and the date and time of transfusion, the volume, or in adult patient, the number of units that you think of transfusion, and also the rate of transfusion in certain patients like in heart failure and volume overload patients, and other special clinical instructions and requirements. If in different patient categories, sometimes you need leukodepleted blood. In certain category of patients, you need irradiated blood. Sometimes rarely you need CME seronegative bloods in transplant setting, or else whether you need to warm blood using blood warmers in patients with cold hemoglobin disease like, and any other drugs that you want to use during transfusions like furosemide or any other drug. Those kind of instructions also has to be included in the prescription. Then patient information and consent to transfusion. So in Sri Lanka at the moment, consent is not legal requirement for transfusion, but in future, when the Blood Act is in place, it will be a legal requirement. The consent would be a legal requirement for transfusion. In the consent that these things has to be covered, the risk, benefits, and alternatives, and you have to explain the patient timely and understandable manner why you need this transfusion and what are the risks, benefits, and if there are any alternatives for transfusion, then the patient will decide whether he or she will take the transfusion or go for the alternatives. And all this information given, written and verbal, should be clearly documented in the patient's clinical records. And the transfusion given while under anesthesia or in unconscious patients, sedated patients, you have to tell them before discharge, if they are rational and conscious, you have to tell them that you have given these transfusions. That is very important, because sometimes in certain situations when we are taking history regarding the transfusion history, they don't know that they have given transfusions or not. These are few examples of patient information that certain other countries use, and also the consent form that they are using to take the consent for transfusion. The transfusion is not risk-free and it always has a lot of hazards. Since all cellular blood product transfusion is a live tissue transplant, so our immune system always recognize this allogenic tissue and mount an immune response against this allogenic or foreign tissues. So therefore, you always have to expect immune reaction from the patient when you are transfusing cellular blood component. Around 10% of all transfusions end up with some adverse outcomes. The transfusion is an independent risk factor for increased morbidity, mortality, and also it will increase the average hospital stay as well as the ICU stay. Therefore, each unit of transfusion is associated with incrementally increased risk of adverse outcome. Therefore, people have developed a model which we call patient blood management to mitigate this adverse outcome to this patient. So the patient blood management is a patient-concerned, systematic and evidence-based approach to improve patient outcome by managing and preserving patients' own blood while promoting patient safety and also the empowerment of the patient. PBM is also aims to improve clinical outcome by avoiding unnecessary exposure to blood components. It described by including 3 pillars. These 3 pillars are, the first pillar is the detection and management of anemia and also the iron deficiency especially. The second pillar is minimization of blood loss and optimization of the coagulation function of the patient. The third pillar is optimizing the patient-specific physiological tolerance to anemia. So in surgical setting, this slide was for a surgical patient. They have break this down to pre-operative, intraoperative, and post-operative period, how you implement these 3 pillars. But in a medical patient also, you can implement the same thing as the before your specific therapy or during your specific therapy and after your specific therapy as well. So this, in the first pillar, you see the detection and managing of anemia, and in the intraoperative or your specific treatment period, timely surgery with hematological optimization, and in the post-operative period, you see you can give stimulations for erythropoiesis. Likewise, all these in 3 pillars, there are strategies that you can adopt to minimize blood transfusion. So this was initially implemented in Western Australia in 2008. And they have gathered all this data from 2008 to 2014, the 6 years. They have implemented it in all the major hospitals in Western Australia and recruited more than 600,000 patients to this program. And they have published this data recently, and it shows that the mortality was reduced by 28%, infection reduction was 21%, acute myocardial infarction and stroke reduction was 31%, and length of stay in the hospital was 15%. And improvement of the key program indicators as preoperative anemia. So they have reduced the preoperative anemia from 21 to 14%, and the hemoglobin threshold for pre-transfusion hemoglobin threshold from 7.9 grams to, they have decreased it to 7.3, and they have increased the single unit transfusions from 33% to 64%. And it was very remarkable when it comes to the blood product transfusion. They have reduced red cells and plasma transfusion by more than 40%, and platelet transfusion by 27%. And at last, the cost saving. The direct cost saving by blood products only was $18.5 million, and the total estimated cost reduction is around 100 million. So the advantages of this patient blood management was it significantly improved population health, clinical outcomes of surgical, medical, and obstetric patients, and it definitely reduced the healthcare cost and improve patient safety, and it advances patient education and empowerment, and it significantly reduced the demand for allogenic blood components. And it is very important in these days for countries like us in low and medium income countries. It helps to mitigate some of the resource constraint in healthcare. So beneficiaries, who are the beneficiaries of this patient blood management? Definitely the patients, pregnant women, and individuals suffering from micronutrients and deficiencies, micronutrient deficiencies and bleeding. And it also benefit the hospitals as whole, healthcare professions, healthcare authorities, as well as health insurance in those countries where they have to, the insurance has to bear all this burden. So recently the World Health Organization has published this the policy brief, which they call the urgent need to implement patient blood management, and they very recently they have published the draft proposal structure for implementing patient blood management in their around all these member countries. So we are also in the process of implementing patient blood management in Sri Lanka. We have initiated the Sri Lanka College of Transfusion Physicians as well as College of Anesthesiologists. Was in collaboration, we are in the initial process of implementing patient blood management. You will hear about patient blood management in future in large scale in Sri Lanka as well, while this the program is implementing around the hospitals. So the most important thing in my talk is that in medical patients, what is the effects of blood transfusion on patients' outcome. So this is a national comparative audit which was done a few years back, collaborating Royal College of Physicians UK and NHS Blood and Transplant. So they have seen that in medical patients, the red cell transfusion is around 57%, and the most transfusions were received by the patients who are above 50 years old. And the main clinical indications that they have identified for in medical patients are non-hematological anemias and hematological anemias, as well as the GI bleeds. So the red cell transfusion should not be decided by hemoglobin concentration alone, but it should also be based on the assessment of the patient's clinical status. So we always tell, do not treat the investigations, but to the patient as a whole. So every unit is an independent clinical decision. This decision is based on patient symptom, but not only on hemoglobin concentration. So this tagline, every one matters, was introduced a few years back in UK, where they had the practice of 2-unit transfusion. We also had this 2-unit transfusion when we are junior doctors. So our consultants always tell us to give 2 units of blood. It's like a knee-jerk response. If the patient is anemic, give 2 units. So now we always tell the clinicians, give 1 and reassess the patient and decide on the future transfusion. So always it is an independent, every transfusion is an independent clinical decision. You have to decide one transfusion and reassess the patient, the laboratory parameters as well as clinical signs and symptoms. You have to assess and decide on the subsequent transfusion. It's very, very important. So the hemoglobin levels where we decide on patients' blood transfusions. So HB of less than 7 grams per deciliter, we always tell it's appropriate to give blood transfusion if the patient's hemoglobin level is less than 7. And but still transfusions may not be required in these patients where the patient is well compensated and where there are other specific therapies like iron or any other erythropoiesis stimulating agents. So in HB of 7 and 10, that is the gray area where it has to be based on the need to relieve clinical signs and symptoms of anemia. And in this category, the single unit transfusion is very, very important. You have to give a unit and reassess the patient and decide on subsequent transfusion. In HB of more than 10, it's very unlikely that the patient need blood transfusion, and continuous reassessment of the patient is necessary in this group of patients. In patients with iron deficiency anemia, iron therapy is required to replenish the iron stores regardless of whether you transfuse or not, because it always happens in our setting where patients with iron deficiency anemia, you give blood and send them home. So they come in another 2 months with the same symptoms because you have not replenished their iron stores, you have only relieved their symptoms. So you have to assess their iron status, and you always have to replenish their iron stores before sending them home, because the blood transfusion is only a symptomatic, give them a symptomatic relief. So this is the landmark study that changed the practice of transfusion medicine. It is a multi-center randomized clinical trial in critical care where they have compared restrictive transfusions and liberal transfusion strategy in critically ill patients. And they have found out that the restrictive transfusion strategy has good outcomes, and the liberal transfusion strategy has the worst outcomes. So after that, there are quite a few trials happened in the world, and there are a lot of publications of those trials. And this is one in septic shock. Again, the liberal transfusion policy and restrictive transfusion policy, they showed that there are no survival benefit. So these are a list of randomized clinical trials happened last few years and shown that the liberal transfusion strategies does not shown any clinical benefit, and in some trials they have shown worse outcomes in surgical as well as in medical patients. When it comes to specific disease conditions, in the acute coronary syndrome, HP of less than 8 grams per deciliter, RBC transfusion may be associated with reduced mortality and likely to be appropriate. And in patients more than HB of more than 10, the transfusion is not advisable because it associates with increased mortality. In heart failure, There's an increased risk of transfusion-associated circulatory overload. Therefore, when indicated, all transfusion should be of single units. And also, you have to reassess the clinical efficacy as well as fluid status for subsequent transfusions. In well-compensated upper GI bleeding, more restrictive approach is beneficial. So this trial, sometimes you may have already seen this one. The transfusion strategies for acute upper gastrointestinal bleeding, which was published in New England Journal of Medicine. And, and it clearly showed that the restrictive transfusion strategy has survival benefit over liberal transfusion strategies. In anemic patients with chronic kidney disease, erythrocyte stimulating agent therapy is always necessary to avoid red cell transfusion after consideration of risks and benefit. The recommended HP target is, most of the study showed that it is around 10 to 11. The significant increased risk of mortality is there in high HP levels, and also high HP levels are associated with increased risk of hypertension, strokes, as well as hospitalization. This is the systematic review of clinical trials that they have published in 2012, and it clearly showed that the restrictive transfusion strategy in CKD is again beneficial. But in patients with thalassemia, maintaining pre-transfusion hemoglobin of 9 to 10 is necessary. They have little higher transfusion threshold because you all know that we want to suppress their extramedullary erythropoiesis. Therefore, they usually have little higher transfusion thresholds. And also, it is necessary to plan their transfusions in monthly intervals, again to minimize the effects of extramedullary erythropoiesis. This is again a question sometimes a lot of clinicians will raise, whether they need fresh blood for their patients for transfusion. This trial is again published in New England Journal, the age of transfused blood in critically ill adult. It has clearly showed that the standard blood, that is more than 22 days old blood, as opposed to the fresh blood, which is less than 6 days old blood, has no difference when it comes to the survival. So the standard blood has the same survival benefits than fresh, what they call fresh blood. So there are very few indications where you need fresh blood for transfusions, like intrauterine transfusions and transfusions, especially exchange transfusions for neonates. Most of our medical patients, they don't need fresh blood. The standard blood would be equally effective as fresh blood. So in medical patient, what is the effect of FFP and platelets when it comes to the patient outcomes? This is again the same national comparative audit. The medical patients and medical wards, as well as the intensive treatment units and high dependence unit, consume significant amount of fresh frozen plasma. And the main indications that they consume fresh frozen plasma is for liver disease, as well as for the reversal of warfarin over anticoagulation. The routine use of FFP in medical patients with coagulopathy, including liver impairment, is not supported. So test for coagulation correlates poorly with bleeding risk in liver impairment. I'll come to that in next 2 slides. The underlying cause of coagulopathy should be assessed and always treated. When FFP transfusion is considered necessary, the risk and benefit should always be assessed for each patient. So most of you must have come across this situation where in liver disease patient, when if you want some interventional radiological support, they always ask for correct INR before sending to the radiology department for paracentesis, so liver biopsy and also. But the patient you always has the challenge how to transfuse to this patient because they are always overloaded. So in liver disease patients, they have the rebalance, they are in a state of rebalanced hemostasis. In normal hemostasis, we are in a fine balance between procoagulants and anticoagulants. That's why we usually don't bleed. We are in a fine balance with procoagulant and anticoagulant activity. In liver disease patient, what they are also in a balanced state. It's a new balance because their procoagulant as well as the anticoagulant activities are low and they are in a new balance. So you will see in the last box how they are the factors promoting bleeding as well as factors promoting thrombosis also are in reduced state. So in the factors promoting bleeding, they are in a thrombocytopenic state, and there are certain clotting factors, especially the factors, vitamin K dependent clotting factors like 2, 7, 9, and 10 are in a deficiency state, and their fibrinogen levels are low, and their anticoagulant activities are low, and the factors promoting thrombosis like they have elevated levels of all Willebrand factors, factor and factor A, and their ADMTS13 activity is low, and they have decreased level of protein C, protein S, and antithrombin. Therefore, both their procoagulant and anticoagulant activities are low. So when you are assessing this patient hematologically, you send PT and INR, and PT and INR show the procoagulant activity. So you clearly see that their procoagulant activity is low. So definitely you will get an elevated INR and PT. So you try to correct the INR by giving FFP. So what is the effect of fresh frozen plasma on INR? The mean INR of fresh frozen plasma is 1.1. We take blood from healthy volunteers, so we assume that their INR is 1 because of these anticoagulants that we introduce into the blood pack, dilute the clotting factors, and therefore usually the mean INR is 1.1, and it ranges from 0.9 to 1.3. Therefore, it has very little effect on minimally elevated prothrombin type, but it has a significant effect on big difference between the patient's INR and the INR of the FFP. You will see here the mean change of INR is 0.03 per unit of FFP. If the INR is close to 1, by giving FFP, you will not get much of a benefit. But if the INR is very high, like 2.5 or 3 or 3.5, and it definitely will you will get a significant reduction in INR by giving FFP. Therefore, minimally elevated INRs don't try FFP just to correct their INR values. But the other important thing that this paper has revealed is that only 10% of patients had the PT rechecked after transfusion of FFP. That is very important. If you transfuse, you have to reassess the patient. Otherwise, no point giving these transfusions. So that also you have to keep that in your mind, that when you are giving FFP to correct INR, you have to reassess the patient to see the benefits. This is again a systematic review of 80 randomized control trials on FFP use, and all the indications, common indications like liver disease, cardiac surgery, warfarin reversal, burn, shock, and head injury were covered in this trial, and they have covered the prophylactic and therapeutic use of fresh frozen plasma. And all these trials has shown us no significant benefit of use of FFP across all these common indications. So when it comes to platelets, the same national comparative audit on blood transfusion has shown the medical wards are consuming the majority of platelets. 57%, more than half of the platelets are going to the medical patients. So when it comes to platelet transfusion may be indicated for the prevention and treatment of hemorrhage in patients with thrombocytopenia or acquired or congenital platelet function defects. And platelet transfusion are not indicated in all causes of thrombocytopenia. And some thrombocytopenias, they are absolutely contraindicated, like thrombotic thrombocytopenic purpura and heparin-induced thrombocytopenia. In your practice, I think that in dengue also you are now you are not transfusing platelet, and it's proven that the platelet transfusions has adverse effects on dengue as well. So the cause of thrombocytopenia has to be established in all possible cases, and if you need platelet support, always expert opinion should be sought. In patients with bone marrow defects and their production of platelet is reduced, like myelodysplasia or aplastic anemia, specific threshold for transfusion is not appropriate, and you have to assess the patient and assess the risk of bleeding and decide on their platelet transfusion. These patients, you have to manage them individual basis in consultation with relevant experts like hematologists. Long-term prophylactic transfusions for these kind of patients has more risks and complications like alloimmunization and platelet refractoriness. And if you unnecessarily transfuse this patient and make them alloimmunized for platelet antigens, and if they have platelet refractoriness, what will happen if there is a significant bleeding? Sometimes platelets won't work. Therefore, you have to be very careful when you are transfusing platelets for these kind of myelodysplasia patients like MDS and aplastic anemia. What are the risks of bleeding in these different platelet counts? So I think you all know this. Platelet count of less than 5 has very high risk of spontaneous hemorrhages, and platelet count between 5 to 10 has there's a risk which is increased with trauma, surgery, and ulceration. And from 10 to 50, the risk is variable, and more than 50, the risk of bleeding is very unlikely. what are the current recommendations for platelet transfusions? If the platelet count is less than 5, the transfusion is almost always necessary. And 10 to 20, it is the prophylactic window for our medical patients. And less than 50, it is usually indicated for surgical procedures and other invasive procedures. But if the patient is going for major surgery or spinal or epidural anesthesia, you have to have around 75 or at least 80,000 platelet count. And between 50 and 100, you have to give transfusion based on their risk of bleeding. And more than 100, it is very unlikely you need transfusion, platelet transfusions, unless if they are having severe platelet dysfunction. If the patient is undergoing a chemotherapeutic procedure, especially chemotherapy or hematopoietic stem cell transplantation, the prophylactic platelet transfusion threshold is less than 10,000 in absence of any risk factors like fever or infection. If they have fever infection, you have to give platelets in a platelet count of 20,000. Are there any therapeutic alternatives to blood or blood transfusion? There are red cell substitute and synthetic oxygen carriers to substitute red cell transfusion, but they are still in the trial state. There are few synthetic carriers and red cell substitute. They have done phase 2 and phase 3 trials, but still not in therapeutic use. But for coagulation purposes, to treat coagulopathies, you have quite a few alternatives. Tranexamic acid is one. So this is the first trial that was done on tranexamic acid. That is the CRASH 2 trial, which was on traumatic bleeding trauma patients, and they have shown that the tranexamic acid has significant benefit of the all-cause mortality and also the death due to bleeding. And it also significantly reduced the blood product transfusion as well. Followed by the CRASH 3 trial, which was on traumatic brain injury. It also has shown that the tranexamic acid is safe in traumatic brain injury, and it reduces the death due to head injuries. Then the woman trial, which was on postpartum hemorrhage, and it also shown that the tranexamic acid significantly reduced the postpartum hemorrhage related deaths. What about medical patients? The whole IT trial, which was on GI bleeding, acute GI bleeding, and it unfortunately has shown that tranexamic acid has no benefit in acute gastrointestinal bleeding. But still, we sometimes use in severe GI bleeding, tranexamic acid we still use, but this trial has not shown any therapeutic benefit in upper GI bleeding. The fibrinogen concentrate, and it can replace cryoprecipitate as well as FFP. And it is virally inactivated and lyophilized powder. But fibrinogen concentrate is not licensed in some countries, including Sri Lanka. 60 milligram per kilogram dose will increase fibrinogen by 1 gram. And the benefits of fibrinogen concentrate is it is very fast reconstitution, viral and immunological safety, less volume, easy of use. But the disadvantages are it will not supply other procoagulant factors, and also the cost. Before this, our economic crisis, it was 1 gram was cost around 100,000 rupees in Sri Lanka. It was available in Sri Lanka, but not licensed yet. Then prothrombin complex concentrate. There are two forms available. One is 3-factor PCC and the 4-factor PCC. 3-factor has factor 2, 9, and 10. 4-factor PCC contains factor 2, 7, 9, and 10. Treatment of or prophylaxis of bleeding in deficiency of any vitamin K dependent coagulation factor is the common indication. And again, the urgent reversal of warfarin-induced anticoagulation in patients presenting with major bleeding like ICH, or patients who need urgent surgery who are on warfarin. Therefore, this prothrombin complex concentrate we commonly use in ICUs. Therefore, it's again a substitute for the FFP. So, in conclusion, the PBM is the new standard. It is the new standard of care, and the goal is to prevent bleeding, anemia, and transfusion in these patients. The restrictive transfusion is safer than liberal transfusion strategies, and there are few safe alternatives for correction of coagulopathy than giving blood transfusion. So I think I have covered the things that I want to elaborate on you. So if you have any questions, I think you can ask in next 10 minutes. Thank you.
Thank you, Dileetha. That was really interesting, and I actually learned a lot. There's one question in Q&A. I think you can also see that question.
So we'll see.
Do we have to transfuse platelets in dengue patient if platelet count less than 5 or restrictive strategy? That was the question.
Yeah, it again depends. So you have to assess the patient, the fluid status, and in which stage the patient is in, and also the bleeding risk. So depending on that, you have to decide. I can't tell exactly that you have to give platelets even if they have platelet count of 5. So that there are patients where we have managed and recovered where they gone through that very low platelet counts and recovered. Yeah. So we have seen that if you give platelets, there are a lot of complications, and their recovery is very slow as well. So if you can, it's better to avoid platelets and manage the patient.
Yes, Dileetha, I agree with you. As a physician, we are the people who manage this DHF with this kind of platelets.
Yeah.
And we usually don't give platelets unless really necessary. You all know the dengue management. It is the, in case if we need, we do blood transfusion rather than platelet transfusion. So I agree with Dr. Dileetha's answer. There are a few other questions.
Yeah, what are the indications for washed red cell transfusion? Actually, washed red cell transfusion is indicated for patients who are getting repeated allergic reactions or anaphylaxis. So that is the only indication for washed red cells. But in certain situations, because of we know that we are in a country with a lot of resource constraints. So in a patients who need leukoreduced blood, sometimes we don't have leukoreduced blood because the specific blood bag types are not available. In that case also we give washed red cells because it's better than giving standard blood. Therefore we wash red cells in for those patients as well. But if you ask me the indication, the only indication I can tell you is the repeated allergic reactions to blood. because the washing will remove all the plasma proteins, because patients are allergic to plasma protein, not to red cells. So therefore, the whole idea is to remove all the plasma proteins and resuspend these red cells in saline and transfuse. Have I answered the question? Yeah. What is the target HP you recommend for patients with
ischemic heart disease?
Ischemic heart disease, yeah. Ischemic heart disease, as I mentioned in this slides as well, the 8 is the guideline says it is 8. Less than 8, only you transfuse. But if there are other comorbidities, like if their heart is very weak and with a very low ejection fractions where the oxygenation is very poor, sometimes we give red cells in a little higher targets also. And these trials have shown that if you are giving red cells for hemoglobin more than 10, it usually complicates the disease. Right. Are there any other at the bottom? Yes. What are recommended dose of, sorry, this?
Albumin is not available currently. What are the alternatives for albumin in that case? FFP has a place.
Yes, if it is solely for albumin replacement, the blood product that I recommend is the cryosupinant plasma or the cryopure plasma, which is once you remove cryoprecipitate from the fresh frozen plasma, what is left is the cryosupinant plasma, which does not contain the lot of clotting factors and fibrinogen. So it basically contain plasma protein. So the best option would be a cryosupinant plasma, because if you give FFP for sole albumin replacement, if you unnecessarily give clotting factors like factor 8, 1 Willebrand factor, as well as a lot of fibrinogen. So it sometimes may precipitate thromboembolic events as well if you are giving large doses. So therefore, if you don't have albumin, the better option would be to give cryosupinant plasma.
So the alternative to Jehovah's Witnesses.
The alternatives in the sense, the other than blood products, I mean. So we come across Jehovah's Witnesses. So the challenging situation is the surgical patients. So in surgical patients with Jehovah's Witness, what you have to do is you have to assess the patient separately. You have to take a thorough history of the patient's coagulation history, their coagulation status, their family history of bleeding disorders and all. Then you have to do iron studies of this patient because you have to replenish the iron stores before, if they are going for a surgery, and you have to give some time if it is a routine surgical procedure to increase the HB level. And in intraoperative period, there are a lot of things that you can do. You can adopt surgical techniques to minimize bleeding. You can save cells by using cell savers, or the anesthetic techniques are also important, where you have to apply hypotensive anesthetic techniques to minimize bleeding. In the post-operative period also, you have the pain relief, prophylaxis of infections, prophylaxis of DVT. Those things are important. In a medical patient also, you can apply most of these things when it comes to Jehovah's Witness. So nutritional anemias, you have to treat with the B12 folates, iron, and you can give them erythropoiesis stimulating agents as well. And the consent is the most important thing, because you have to talk to them for what treatment modalities they are okay with. So some patients, they say that they are not taking only red cells, but the yellow components, they are okay. But certain people, they are not okay with the yellow components like effective platelets as well. And most of the patients, they are consenting for cell saving. But I have came across one patient who has not consented even for the cell saving as well. So it depends. It depends on their beliefs as well. So all these, the treatment modalities, they are agreeing. You have to document and take their consent, because in Jehovah's Witness, in Sri Lanka, it's variable. It depends. But if you go to UK and if you want to manage this patient, they come with the priest. So the patient hardly talks, the priest talks. So they usually don't give consent for any of those alternatives, most of the alternatives that we offer. So in Sri Lanka, it's not came to that state even yet, and the patients come alone, and you can talk to them and convince for certain treatment modalities. And there's one the court order, the famous one in UK, where there was a sickle cell anemia patient, child, and they need, he came with a sickle crisis, and they need red cell exchange. And the parents were the Jehovah's Witnesses, and they have not given consent for red cell exchange, but the trust has gone to court and took a court order because the patient is not in a position to decide. So what the court decided was to go ahead with the transfusion. So it's a little bit tricky still in
there are other clinical questions. We'll go to that.
Yeah. What do you consider for when do you consider 3-factor or 4-factor PCC? So usually 3-factor PCC has, we don't have that much of indications for 3-factor PCC. Only indication is if there are congenital deficiency of factor 2, 9 or 10, you can give 3-factor PCC. But if it is a liver disease or warfarin reversal, definitely you have to use 4-factor PCC, because warfarin as well as liver disease reduces all 4 clotting factors, which are 2, 7, 9, and 10. So what is the recommended dose of platelet in case of?
I think they have asked, like, if there's indication for platelet transfusion, how many platelets you are going to give, how many packs of platelets?
Yeah, for that adult dose is 5 to 6 units of platelet. 1 unit of platelet contains around 15 to 10 into power 9 platelets. So adult dose is 5 to 6 units. If it is a pediatric patients, we usually give 10 to 15 ml per kg. What are the difference between washed leukodepleted and irradiated blood? What are the specific indications? Irradiated blood, irradiation is entirely a different process. Irradiation is necessary to knock down the T lymphocytes in the blood, because these T lymphocytes can precipitate transfusion associated graft versus host disease. So in certain immunocompromised patients, the allogenic T lymphocytes will go and engraft in the recipient, and it will precipitate transfusion-associated graft versus host disease. It's a lethal condition. There's no cure, and the mortality is more than 99%. So in those patients whose immune system is compromised due to drugs or congenitally, you have to give irradiated blood. But leukodepletion is only for prevent HLA and low immunization. So it will remove, it will reduce the transfusion, the febrile transfusion reactions, and also platelet refractoriness, like those kind of things. And therefore, it's entirely two different clinical settings. We use leukodepleted and irradiated blood. In medical patients, mainly we use irradiated blood after certain chemotherapeutic agents like fludarabine and bendamustine. If you are using those drugs, and also the common drug that you use, ATG. After those therapy, you have to give irradiated blood because their allo recognition is reduced. Therefore, there's an increased risk of transfusion-associated graft versus host disease. Please explain the use of thromboelastography. Thromboelastography is a dynamic test where you record the patient's procoagulant as well as anticoagulant activity. So the conventional tests of coagulation like PTA, PTT will only give you the information of procoagulant activity. But in thromboelastography, it will give a whole, you will get a whole idea of the clotting process, from clot initiation, propagation, stability, and also the clot disappearance after fibrinolysis. So it will give you all this information. Therefore, you can get an idea of the whole coagulation activity of this patient. So that is the importance of thromboelastography. It's usually indicated in acute bleeding situations, and doing prophylactic sort of thromboelastography is not indicated. It's not proven for those kind of situations, but acute bleeding, any acute bleeding, surgical bleeding, upper GI, or postpartum hemorrhages, you can use thromboelastography. And how much platelets are being provided by 1 unit of platelets, and how much of raise? Right. 1 unit, I already have mentioned, 15 to 10 into power 9 platelets are there in a single unit of platelets. And adult dose is 5 to 6 unit. And the increment that we expect in non-bleeding patient is 10 to 20,000 increment of platelet counts after single adult therapeutic dose. So, but in a bleeding patient, you can't, or patients with platelet refractoriness, you don't get that much of increment because of platelet consumption and also platelet destruction.
And
there's
a question in this chat box.
Okay.
You can read this: place for tranexamic acid in patient with history of DVT or treatment for DVT.
Yes, in DVT, it's relatively contraindicated, and also in DIC, it's relatively contraindicated because it promotes the thrombosis. So therefore, you have to make sure that patient is not prothrombotic before prescribing tranexamic acid.
Thank you, Dileetha. So I think Dileetha has answered most of the, almost all the questions, and we learn a lot, Dileetha, and it's really interesting discussion. I would like to thank you very much for spending your time over this. And I would like to thank Sri Lanka College of Internal Medicine, our president and the council, for organizing this, and our sponsors, Gets Pharma and Mr. Dishan Fernando for IT support. We will meet in next month with another Senior Registrar Forum, which will be on chest X-rays. Thank you very much.
Okay, thank you very much, Premali.